All right, so we're going to start with COPD first. So what is COPD? It is chronic obstructive pulmonary disease. Did you guys know that COPD has two categories, which is chronic bronchitis and emphysema? So we're going to dig a little deeper into those two. All right, you guys, so before I go into chronic bronchitis, I want to mention that I did post a respiratory assessment video that's by registered nurse Sarah, and she goes over the anatomy of the respiratory system, and I think it's a great video to watch to know when I talk about the bronchioles, when I talk about different parts of the lungs, you'll actually know what it is. So either you need to watch that video or brushing up on your anatomy. All right, so what is happening in breathing with chronic bronchitis? So in chronic bronchitis, the bronchioles become damaged. This damage leads to them being thick and swollen and deformed. This is accompanied by more sputum production. This limits the ability of a person to be able to completely exhale the air they take in. So when they take in another breath, it will increase the air volume even more. So because they have retained air from the previous breath, this leads to hyperinflation. So what actually is happening? That patient is not able to exhale, meaning push out all the air that they brought in. So by the time it's time for them to breathe in another breath, that old air is still in there. So let's think about it. When we have a balloon blow, like if you don't let all the air out and you blow some more in there, guess what? It keeps getting bigger and bigger. So it says also less oxygen is getting into the blood and more carbon dioxide is staying in the blood. So we breathe in oxygen and we breathe out carbon dioxide, right? But if we're not breathing out the carbon dioxide, where is it going? It's staying there. So this leads to low blood levels and high carbon dioxide levels. Patient will have stenosis due to decreased oxygen level. To compensate, the body increases the red blood cell production and causes blood to shift everywhere else, which increases blood pressure in the pulmonary artery, leading to pulmonary hypertension. And then pulmonary hypertension can lead to right-sided heart failure. But we're not getting into heart failure. But just know that this patient is not breathing out the carbon monoxide like they should, carbon dioxide like they should, sorry. So it says that the name blue bloaters is due to cyanosis from hypoxia and bloating from edema and increased lung volume. The bloating is from the effects of lung disease on the heart, which causes right-sided lung failure. So remember, blue bloaters, blue bloaters. All right, so what happens in your breathing with emphysema? So hyperinflation. So what was hyperinflation? When we're keeping so much air in our lungs, right? Hyperinflation caused the diaphragm to flatten. The diaphragm, what is the role of the diaphragm? That's what I'm saying. It's so important that you go back to your anatomy. But the diaphragm plays an important role in helping the patient breathe in and out, right? Therefore, in order to fully exhale, the patient starts to hyperventilate and use their accessory muscles to get the air out now. Over a continued amount of time of doing this can lead to a barrel chest look, right? And during all that, you expect it to be noted there is an increase of the anti-posterior posture diameter. So I'll show a picture coming up, but you can see how their chest wall is so much different. So basically, the diaphragm starts to get flattened, and I'll show you for that actually to make sense. But the diaphragm now is flat, and the patient starts to have this barrel chest look because they're trying to get that air out, right? That air that's in there that's not supposed to be in there, they're trying to get it out. All right, so the damage in the sac causes the body to keep high carbon dioxide levels and low oxygen levels. So they have a bunch of carbon dioxide and not enough oxygen in their blood. So inhaled oxygen would not be able to enter into the sac for what? Gas exchange, and carbon dioxide won't leave. Right? Does all this making sense? So basically there is an issue with getting the air out of the lungs to be able to push out the carbon dioxide. So the body tries to compensate by hyperventilating, right? So what is hyperventilating? We calling it puff. Like you huffing and you puffing, right? You hyperventilating. And the patient will have less hypoxemia, meaning they'll have less blood in their less oxygen in their blood, so they'll have a pink complexion than chronic bronchitis, which you will see cyanosis. So they'll have more oxygen in their blood versus and with chronic bronchitis they'll have cyanosis. But in this one you will have a pink complexion because you're at least getting some type of blood flow there. So because pink puffers keep oxygen levels just where it needs to be for hyperventilation, so they're not getting all that they need, but they're getting something. They're getting more than in our patients with chronic bronchitis. So the person in chronic bronchitis, they are the blue bloaters, right? Blue, cyanosis. With these guys, they're pink because they're getting some level of oxygen. So let's pay attention to what the slide says. The slide says the name comes from hyperventilation, puffing to breathe, and the pink complexion. They maintain a relatively normal oxygen level due to rapid breathing. So I don't want to pass out, but just straight out, due to that rapid breathing, they're still able to get oxygenated blood to the lungs and all that kind of stuff, and in the blood stream. So we're still able to get that, right? So rather than stenosis in chronic bronchitis, so in emphysema, the alveolar sacs lose their ability to inflate and deflate due to the inflammatory response of the body. So the sac is unable to properly deflate and inflate. So inhaled air starts to get trapped in the sacs, and this causes major hyperinflation of the lungs because the patient is retaining so much volume. All right, so I think this cartoon is perfect. So you can see the blue bloater. So you see how it says on here, it says it is an airflow problem. That's why that patient is blue, because they're cyanotic, because it's an airway problem, right? Because if you have so much, and I'm going through it again just to bring it all home, if you have leftover oxygen in your lungs, leftover air in your lungs from the last breath, and then the other breath come in, and then you're just adding on to it, your lungs are going to reach a capacity where it can't take any more air in. So that patient, your lung capacity is just going to start getting bigger and bigger until it can't hold in anymore, right? And then on your emphysema, your pink puffer, that is a CO2 retention. Air is not now able to escape as well, but we're going to start hyperventilating, right? So they're going to be a minimal of cyanosis, but guess what? We're going to be retaining your CO2. All right, I hope this makes sense for you guys. All right, so what are some complications of COPD, right? So the biggest one that we see now is heart disease. So it is so important to know that your lungs and your heart, they work together. They work together. So heart failure is big in these patients who have COPD. They could have a pneumothorax, which we'll talk about in class. They could be at risk for pneumonia, right? And we'll talk about pneumonia later on. And they could be at risk for lung cancer as well. So what are some signs and symptoms? It would be perfect if you go back to that picture. But Nurse Sarah, she came up with this mnemonic, lung cancer. I believe cancer is on the next slide. And it says L, the lack of energy. Why? Why are we going to have a lack of energy? Because we have a lack of oxygen, right? We have a lack of oxygen. Our body cannot keep up with the demand of oxygen. They're going to be short of breath, unable to tolerate activity, poor nutrition, weight loss due to energy used for breathing. They're not going to want to eat. They're going to be tired because all their energy is going to be used up for breathing. Gas, now fluid and electrolytes is back, you guys. So this patient will be respiratory acidosis. Why? Because of the high CO2 level. I'm sorry, y'all. It is lung damage, not lung cancer. So the rest is damaged on the side. So it's saying dry or productive cough. Maybe a consistent cough, especially with chronic bronchitis, right? Because we said that chronic bronchitis was what? With a productive cough, chronic bronchitis increased the what? The sputum, all right? So accessory muscle usage, right? When they're breathing, you will see diminished. You'll see coarse crackles or wheezing. Modifications of skin color. We talked about the cyanosis and the cyanosis color. Your anterior posterior diameter, that's that barrel chest, right? In that patients, they get in a triad position when they have shortness of breath. So they'll be like this. You will see your patient start to do that, and extreme dyspnea. So those are some signs and symptoms that you want to look for in your patient. So what are you going to do as the nurse? Assess, 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 assess. A, B, C. A, B, C. Airway. We're in respiratory. So anytime it comes to priorities and we're in respiratory, we gotta go with airway. So you want to make sure that you monitor their respiratory status, that you're assessing their lung sounds, right? With lung sounds, you can see if they need to be suction or not, if they have a trach, if you can hear secretions in there where they need to cough and deep breathe more, where they may need to use the ascending spirometer to open up the lungs to clear out some secretions. You definitely, if the patient is having any sputum production, anything productive coming up, especially if it's a yellowish greenish color that could signify a infection, you want to tame a culture. If order, obviously the doctor has to order, but you can bring it to the doctor's attention like, hey, the sputum that she is spitting up, it doesn't look good. I think we should get a culture of it. And you want to keep their oxygen saturation between 88 to 93. You want to keep their oxygen saturations from 88 to 93. And you're like, Dr. B, 88, that is low. But there is a rule for COPD patients. So it said patients with COPD are stimulated to breathe due to low oxygen rather than high carbon dioxide levels, which is opposite for people with healthy lungs, right? If they are given too much oxygen, it will reduce their need to breathe and it will cause them to hypoventilate, and carbon dioxide level will increase the toxic levels. So think about it. Patients with COPD, their lungs are now lazy. Their lungs are lazy now. And their lungs are saying, I'm going to breathe when oxygen level are low because I know I have to work. But if you give me oxygen, guess what? I'm about to chill out and relax. Because first of all, I've been working overtime anyway, right? We're working overtime. We're hyperventilating. We're doing all this stuff to try to keep this patient afloat. But if you give me oxygen, oh, I'm going on vacation. And I'm just going to forget to breathe altogether. So you want to make sure that you don't give them too much oxygen. Not saying that that patient can't get oxygen. Patients with COPD cannot get oxygen at all. No, low amounts of oxygen. If we can get them between 88 to 93, hey, we're good. And that patient is not complaining of any shortness of breath, chest pain, and all that stuff, hey, we're good. So you want to make sure that you teach your patient different breathing mechanisms and all that kind of stuff. So let's teach them pursed lip breathing. What's that? Right? So you want to do that. So remember, these patients don't fully exhale well, right? So you want to encourage them this type of breathing technique, especially when they start to get out of breath, right? And you want to encourage them to use their diaphragm to breathe. So a lot of times This is the use of your accessory muscles. You want to tell them to breathe from the abdomen. Breathe from their abdomen. Right? So when you breathe from your abdomen, this helps make your diaphragm stronger. It slows down your breathing rate. It decreases your energy needed to breathe. And you can use this with pursed lip breathing as well. You want to give that patient breathing treatments as well as order. And remember about the oxygen. That is so important to remember about the oxygen, you guys. We can also oxygen therapy, all that is on there right there. They also can have chest physiotherapy where we basically try to mobilize those secretions, right, to get them to clear on out. They can have posterior drainage, different positions right here that can drain drainage and all that kind of stuff. So we basically just want to help clear mucus up out of that patient so they can breathe better. So patient teaching. So nutrition is big with these patients. Why? Because they are using up a lot of energy, right, to breathe. So we want to eat high calorie, protein rich meals that are small but frequent, and staying hydrated if it's contraindicated. So if they have congested heart failure, then that's contraindicated. They may not be needing to eat all these foods like that. Drink all those liquids like that. But we want to teach our patients to avoid heavy, large meals because this can cause compression of the stomach on the lungs. So like when you really get full, you just like, oh my God, it just starts pushing up on the lungs, and that could cause, their breathing to be worse. So you want to tell them small, frequent meals, but let them be high in calorie, let them be rich in proteins. All right, the weather. So you want to tell them to avoid super humid weather, smothering. You ever been in a sauna? I never been in a sauna, but some days in August and in July, South Carolina feels like a sauna. And you ever go out there and it's so humid that you can't breathe? Imagine with a healthy, well, we know how that feels with a healthy lung, but imagine with an unhealthy lung how that patient feels in very, very cold weather. Do you know how it feels when it was like what, 19 or 10 degrees about earlier this year, I think, or was it like in yeah, I think it was like January, early January, how it was when it was so cold that it felt like it was hard to breathe with your healthy lung. Imagine how it is to breathe with an unhealthy lung. So we want to teach them about the weather. All right, vaccines. You want to make sure that these patients stay up to date on their vaccines, on their flu shots, their pneumonia shots, because it's very hard for people with COPD to recover from illnesses. So you want to let your patients know that, hey, you may want to get the flu shot because can you really handle the flu if you get the flu? So you want to teach your patients about their vaccines, and you want to teach them their breathing techniques and medications. So be familiar with your groups, right? Inhalers and all those kind of medicines that we can give for them to help with their breathing.